today. Thanks for tuning in. Really appreciate it. Today on the show, we have Gabby Agin-Liebes. Gabby's a researcher working on the recent Hefter-sponsored study on psilocybin and anxiety, depression reduction for people suffering from cancer. And it got a lot of notoriety in the last handful of days. And it's really exciting because it shows that we really do need to research the subject more, and more funding really is required, and hopefully that happens. So I want to read you guys the bio of Gabby. She sent it to us a couple days ago. Gabby is completing her training towards a PhD in clinical psychology at Palo Alto University. She's a member of Palo Alto University's Early Intervention Clinic Clinical Research Laboratory, which provides and evaluates evidence-based treatments to prevent trauma-related problems in recently traumatized individuals. As part of this research lab, Gabby is examining the effects of trait self-compassion on trauma-related guilt cognitions. Through a supplemental practicum, Gabby is training towards a teacher certificate in insight-oriented mindfulness meditation through the Inner Resources Center at Palo Alto University. Her other research focuses on novel and progressive psychotherapies for a variety of clinical indications, with areas of specialty in anxiety, depressive, and traumatic stress disorders precipitated by life-threatening illnesses. Through the University of California, San Francisco, she is co-leading the qualitative investigation of a pilot study examining the safety and feasibility of psilocybin-assisted supportive expressive group psychotherapy for demoralization and existential distress in older individuals living with HIV. Prior to beginning her graduate studies, she served as project manager of the NYU School of Medicine Psychedelic Research Laboratory, led by Dr. Stephen Ross, in the Department of Psychiatry, where she oversaw the day-to-day operations of trials exploring psilocybin as a treatment for existential distress in cancer patients and ketamine as a rapidly acting antidepressant in emergency department patients. Through the NYU School of Medicine lab, she has received funding to investigate the qualitative experiences of participants undergoing psilocybin treatment for alcohol dependence, and is helping to design a qualitative trial of religious leaders receiving psilocybin at NYU School of Medicine and Johns Hopkins. Her other research interests include the role of self-compassion in addiction recovery and the therapeutic applications of meditation and mindfulness. As you can see, she's a heavy hitter, and we're really lucky to get her on the show. It's been months in the works, and really just grateful to have her here, and I hope you really enjoy it. If you choose to help us out a little bit, share this show with your friends. It's a great way to give your friends kind of a direct understanding from the source, a co-author of these recent psilocybin studies, explaining the story of what happened and how it went down and why it's important. So check it out. And also, if you have a moment, just leave us a review on iTunes. Just log into the store, search Psychedelics today, give us a review of any kind, leave some stars, leave a written review. That'd be great. Really help us out. And thanks again for listening, and enjoy the show.
Yeah, I spent many years at NYU, and the timing, and basically when I left NYU a year and a half ago, the paper was, we had maybe just written a draft or two of the paper, and over the course of the past year, it was really, refining it. But yeah, it was really exciting for it to, after so many years of having been a part of that team and the study, that it came out with such a bang. It was, and was able to push through the Trump dominating, the coverage all over it was kind of interesting and cool to see, like on the New York Times, and we made it the front cover, which is really surprising and cool. And, but to see the Trump juxtaposition and then all the psychedelic healing, juxtaposed with that news. So that was pretty gratifying. But so, and then another big, very exciting week last week for the psychedelic research community, MAPS included. So it was cool.
Yeah, it's actually, I think this interviewing you right now is really synchronistic with all that. So I'm kind of glad that it got all pushed back, and now your your article just got released, and so yeah, perfect timing, I think.
I know. I think this is ideal, and it was interesting to synchronistic also, I guess, for other reasons. This past weekend, so Rick Doblin was scheduled to speak, months ago at the CIIS. I'm not sure if how much you may be aware about the training program they have there, and they just graduated their first cohort. So they had scheduled months ago Rick Doblin, for him to come give the closing talk, and it just so happened that he had his big week days before, and so there was a lot of nice energy and buzz this weekend in the kind of psychedelic research community. So I was able to connect with Rick, and he he's feeling very hopeful. I mean, definitely still a lot of hurdles to get beyond specifically for the MDMA. I mean, it's a little different for MD and the MDMA and the psilocybin work, but generally this week kind of seems to, the response, the coverage seems to kind of indicate that it'll be, there's an auspicious future ahead. So it's great, barring Trump and all
So how
that.
did you first kind of get involved in the field?
Yeah, you feel like you can sometimes start your story as far back as even childhood. But I'll start when I sort of became more intellectually curious and interested in the work, psychedelic research work around college. I was a graduate at the time of NYU, so I did undergraduate work at New York University, and actually was matriculated and planning to attend a master's program in public health a year after I graduated, but instead took a job with a child psychiatrist researcher at the medical center at NYU. So I kind of moved from the university and found a position with another researcher who was developing education programs in the city, and actually at NYU as well, undergrad. So I sort of started my professional career working as a research coordinator for this person. Before I guess it was around the time that I moved to that job. I ended up basically, I'll back up this for a moment. I was very much initially interested in global health systems, so with a sort of psychological focus. So I had taken a number of courses in college that introduced me to just, what would I call it? More like meta thinking about processes and systems, I guess, like systems-based understanding of health. And but what happened was I felt more drawn to psychology and research after taking a class in my last semester of my senior year at college. And this is when I made this sort of change of heart to go into to take a psychology job, because I sort of didn't discover psychology until later in my undergrad career. So what ended up happening was I, at the time, or around the time I had taken this initial job, I heard about Dr. Ross, who was a young psychiatrist at NYU Bellevue, and he was doing this wild study where he was giving psilocybin to cancer patients who had emotional distress. At the beginning of the study, when I first was introduced to the work, the study was had methodologically it was the same as it was when I ended up starting, but the recruitment strategy sort of changed over time, which I can talk about if you're interested. But essentially, I heard about this research that was going on, at the university where I was, at the medical center where I was working, and I was just, I was super intrigued and just sort of intuitively knew that it was, intuitively, I guess, could understand the value, even though I was not yet, I guess, clinically inclined at that time to really make a judgment about it. I just sort of, knew it was a project I wanted to be a part of. So I connected with, I emailed Dr. Ross and essentially just offered to volunteer, to do data entry, and basically volunteer to do whatever they might need. And it was this kind of synchronous, things unfolded in a way that kind of timing wise allowed for my coming on to the team as a coordinator to be actually a really good fit. They really I needed someone right away, actually, in order to resolve a big recruitment crisis that they were in. So when I was hired, I really was hired because the study was in danger of being shut down because they were not getting enough. Interestingly, they weren't getting enough interest. So it was, so they got some money from a private donor to hire someone to kind of exclusively come on and be a coordinator. We're going to do administrative, provide administrative support, but mostly to kind of problem solve this recruitment issue. And so I was hired for that, and worked really hard to think creatively about how to find people mostly within NYU hospital system to enroll. And so I spent, like a year and a half as a coordinator / recruiter. And then the team grew to the point where I kind of matured into a manager of the research lab. So I remained in that position until 2015. And then I moved to California to start my PhD studies.
Awesome. And I forget, did you say you just graduated? So were you doing your master's at the time when you applied, or you just wrapped up your undergrad?
Yeah. So let's see. So I graduated from my undergrad in 2010, and then I worked for a number of years. In the process of working at the medical center on the Psilocybin studies, I took master's level courses. I was in a master's program at the time of actually leaving New York. However, I did not pursue the terminal degree before starting the PhD. So I do not have a master's at this time, but will be receiving a master's through the PhD. Kind of you get a master's before advancing to PhD candidacy. So next year I should be holding a master's if all goes.
Right. Okay, cool. Well. Awesome. Cool. So you were involved in helping enroll participants in this program?
So that was my initial sort of job. One of my job descriptions was to kind of creatively think about recruitment strategies for enrolling people. And at that time, the study, it still very much is I would say it's as a conceptually, I think it's hard for for most even mental health professionals or physicians, it's a completely unusual paradigm, I think, for the traditional healthcare providers, I think, to really grasp. So what happened was, so when I was 2012, I guess, when I really was tasked with this recruitment, I had to think about ways to sort of communicate to oncologists and nurses. My strategy involved really trying to educate the providers of care for people who were patients of the NYU Cancer Center specifically was my target. So I had to sort of learn to speak about the study and kind of present it in a way that seems palatable to people, and had to do that first before I was able to before I was given permission to approach patients. So it was kind of there were layers to figuring out how to, or there were layers to kind of reaching and accessing patients in order to really connect with them enough to have a conversation about eligibility and fit for the study. So that was my initial job, and then it expanded to kind of become more oversight of the study itself and administratively.
Awesome. I'm kind of curious, what type of feedback did you get from like the oncologists having to describe this research? Was it like, or did they kind of understand it, or was there some push against it?
So, there was quite a bit of misunderstanding, I would say, based on, for one, cultural misconceptions, and not just about actually mental health, or not just about the psilocybin, but also kind of about psychotherapy, especially among oncologists who come from such a medical model, which doesn't often, or this is a kind of a blanket statement, but I encountered oncologists who didn't understand the value of just kind of emotional processing post-cancer, or in the midst even of cancer diagnosis. I think it's getting, the field is beginning to recognize the psychosocial needs of cancer patients, but when I first started, I definitely still perceived this lack of understanding about the kind of existential and spiritual and emotional needs of cancer patients. So that's, for one, was a challenge. And then the psilocybin, introducing psilocybin was, for some oncologists, specifically kind of equated psilocybin with other, hard drugs, and it was, and their response was obviously quite negative, and said, some of them said, why would I give my patients, one of these drugs, and I'm trying to keep my patients alive. Why would I, not only, give them something harmful, but potentially waste their time. So there was a lot of criticism, about on those topics. And then, with nurses in particular, I feel like they inherently, or not inherently, but many of them tend to understand the importance of more psychological, emotional needs. So for them, it was a little easier to talk about it. And oftentimes the way I presented the study was much less about, a drug. I really rarely would, or psilocybin, into like the conversations until the end, or the way I would present it was mostly like a trial, psychotherapy trial, medication assisted psychotherapy trial to alleviate existential distress, and then would be able to kind of talk about it from there. But yeah, it was a challenge.
Yeah, it sounds like that. I think Joe and I have talked about that in the past of, how to describe this or talk to people, especially like oncologists or other people in the field without getting some form of rejection.
Right.
So I have a friend who's a palliative care doctor. So I guess that means they stay with the patient until about 6 months before they die.
Yeah.
And tried to discuss a lot of this research. Yeah, this was, before your study was published, and maybe I didn't have the right language to discuss it, but it was a total dismissal, and it was kind of awful to see that the lack of holistic approach. But her whole job is actually coordinating care with all of the different specialists for these people to make them, as happy as possible.
That's so interesting.
So perhaps it would be like a palliative psychologist would be the right approach.
Right. That's so interesting that she seemed to reject. Is that what you said? She seemed to reject the idea.
Right. Yeah. Kind of like the same way you suggested some doctors be like, why would I do that? Why would I give? It's like they heard it the same way you might say, like, why would I give this dying patient heroin or meth?
Exactly.
When it's a totally different thing,
right?
Totally different mechanisms.
Right. Well, I think it is a little surprising to hear that a palliative care, someone working in the palliative care field would dismiss it so quickly. I mean, because I think if they I've met a number of palliative care like nurses, for instance, who do understand the value, and I guess it's sort of it depends. Yeah, it depends on who you're speaking to, but I think that the movement also for palliative care and hospice, emergence of the hospice movement, which is relatively new itself, I think is I expect that barring any, who knows, maybe more. I don't know if it would be political or not between the palliative care movements and the psychedelic movements, but I would hope that they will, I see them as a complementary and, potentially, supportive of each other domains.
Yeah, they totally are like overlapping hugely.
Yeah.
I think perhaps what's happening is, I have a bachelor's in philosophy. I don't have a master's or PhD, or I'm not a doctor as well. So if somebody with a white jacket actually told them about this study from Hefter and you, that, perhaps they would have a totally different reaction. I think also certain generations went through so much DARE education, like never do drugs kind of stuff. And the Reagan, they spent a lot more time living under Ronald Reagan.
Oh, absolutely.
Or at least consciously. So perhaps that's what's happening.
Absolutely. Yeah. I mean, I really, I couldn't agree more about the just cultural, the cultural misconceptions, and there's so much propaganda around, around these substances, and even Rick Doblin, who's kind of like one of the fathers of this work. He has also said that his initial understanding of LSD was that it makes you crazy and it destroys your chromosomes, and I think it's been worse in the Reagan eras, but the propaganda, I think, has run really deep for quite a long time. Despite the fact there has that I think we have evolved to be more open-minded and generally, but we'll have to see how things change now that more papers are being published. But my sense is that it will still take a lot of time to counter those perceptions.
There's still people, I know people who use recreationally, obviously, and they still have this concept in their mind that if they consume one spore, that they'll die. If they, the mechanism of hallucination is that your spine is bleeding, and that's what causes hallucinations.
That I hadn't even. That's the first time I'm hearing that. That is, wow.
Yeah. I've heard it from so many people. It's ridiculous.
Wow. In the 21st century too, we're still hearing these kind of,
right.
Well, yeah, that's something. But
well, there is risk to inhaling spores, at least certain types. I don't think Psilocybin cubensis is going to kill you, but certain food molds would.
Right.
At least put you in the hospital for a minute.
There you go. Exactly.
But yeah, this is like really exciting to, we're recording, what's today, the 5th, and all those articles came out on the December 1st, and MDMA got highlighted. MAPS is moving into phase 3. They just got the approval for that, which is really exciting. And then those 2 journal articles, which you were a part of with NYU, and then the John Hopkins study. So it seems like, things are shifting. I feel like these topics wouldn't be highlighted in mainstream news sources if people weren't a little bit open-minded. So, and the research does strongly suggest that there is potential for medicine, which is, I think captivating people's interest. It's like, wow, look at these results. It's really, you don't see these results very often with, say,
absolutely. And if I may add that, exactly. In addition to kind of just the public perception, I think what's potentially even more powerful is the attention and the commentary and feedback that we've received from key key leaders in the medical field. So the issue of the journal issue that in which that's an NYU and Johns Hopkins co-published the papers. There are, I think it's 9 or 10 commentaries that from leaders, including chairs at medical centers and Ivy League medical centers and past presidents of the APA, which is the American Psychiatric Association, who are basically or generally praising the work and are essentially saying that there is enough, that the trials themselves were conducted in a methodologically rigorous way, that it's it really calls for more research. And I think that's to have very I think I'm in the psychology field, so it's a little I guess it's interesting to see how the movement is sort of moving through the medical fields, at least at this point. And I think there is a lot of strategy on a kind of a larger scale when we think about how to carry psychedelics, into the future. But with these studies in particular, it's really finding a place within the kind of medical establishment. And what's exciting is that the medical establishment, despite the kind of paradigm, the discomfort that comes with, I think, the paradigm shifting, especially within institutions, I think we can all sort of agree that institutions are very attached to all institutions are very conservative, but they tend to kind of be cautious. So we're excited that the papers received really strong commentary that's speaking to the kind of importance of this work and the rigorous nature of the studies themselves. So that's great.
Did you guys receive any kind of worthwhile criticism of the study at all from professionals?
Yes, I think it's definitely fair to say that we did. I think the number one criticism was that so when it comes to, as defined by FDA, gold standard rigor when it comes to clinical trials, it's the randomized placebo-controlled double-blind study. Essentially what that means is a study that is, so let's see, so I'll start with the randomized. When it comes to a drug trial, in order to basically establish effectiveness, the trial needs to be, there needs to be a sort of an assessment for eligibility, and then randomized refers to just randomly assigning people to groups, so there's no bias when it comes to having a control group and a non-control group, and randomization ensures that each group is is equal. And then double blind, meaning that both the researcher and the participant are not aware of of which drug you're taking versus the placebo. And so I'm not sure if I left anything out there, but basically gold standard is this sort of very specific kind of clinical trial design. But the issue is with the double blind piece, where you're basically trying to show that the drug itself and not any kind of placebo, that the participants or researchers were biased by the knowledge of what the person was taking. That's very difficult when it comes to psychedelic research in particular, and a lot of the criticism that was a lot of the commentators pointed out, exactly, perennial problem, pointed out that the blinding itself, they're questioning the blinding, how, the integrity of the blinding procedure. And so this is it's a sort of conundrum when it comes to meeting the FDA standards for, a gold standard design study. Yet it's very difficult to ensure blinding in a study that involves a drug that produces such a powerful effect. And so it's hard to just sort of to really keep that to blind people to what they're getting because of that. So that's one criticism. Another criticism was the sample size. While we were able to pull our data together from our sites, they weren't identical designs, but they were very close. So we were able to together basically argue that we used a sample, that we demonstrated effectiveness among 79 people, which is pretty good. But I think in order to really make a case for this, the efficacy of this treatment, larger sample sizes will be needed. Let me think of anything else salient. Some people think that there may have been selection bias, referring to people who referred themselves or were really highly motivated to get better, and could have affected their outcomes. But As far as I can remember, I think it was pretty positive. It really. One more thing I should mention though is I think someone, I'm not remembering who, brought up the sort of generalizability of, at least population-wise, was limited because our samples are relatively homogeneous and white, middle, upper class. Also, our NYU study we ended up opening our criteria to include people who were not just at end stages of their disease, but who were also considered or deemed to be in remission, or relatively actually healthy at the time of enrollment. So for that reason, it's hard to really, I guess, in that situation, in the NYU study, our studies would then actually be a little bit more generalizable because we used a range of people who had a range of diagnoses, or stages rather, but some people criticized, what's called the internal validity of the study, which refers to, how do we really know that this study is testing what you were trying to test, and it's hard to do that when you have kind of a sample size that is not, or a sample that's who has kind of, there's some diversity, at least when it comes to the diagnosis stage. Does that make sense?
Yeah, it does make sense.
Okay, so
that's interesting. I was just reading over the paper, and I was kind of curious what the admission criteria was. I was just looking, and it said 108 patients were pre-screened, and then 42 gave informed consent, and then 29 received treatment. So, what was like the admission criteria? Like how did the 42 give informed consent, and then only ended up treating 29?
Yeah. So. Okay, so actually, interestingly, we Johns Hopkins, like Roland's team, they screened a lot more than us, but I think what we ended up doing was sort of really only approaching people that were that seemed to be, or people contacted us too, that seemed to be somewhat. That there seemed to be a chance that they could be enrolled, but we phone screened or pre-screened 108, and then ended up enrolling refers to just signing the consent form. So we had, for various reasons, people were ineligible between the pre-screen and enrollment phase because of, let's see. So people actually had, actually, if I can sort of describe the eligibility criteria as I talk about this. So participants had to, the primary indication was cancer-related anxiety or distress, which is kind of a category, or it refers to a very unique kind of distress that is not defined in the basically the Bible of the psychiatry and psychology diagnostic, basically Bible. So in the DSM, there isn't a diagnosis that captures that basically captures the clinical, the clinical manifestation, our target clinical, I guess, indication, which is, cancer diagnosis with anxiety or some kind of anxiety disorder or an adjustment disorder with basically about their cancer. So interestingly, we had a number of people contact us who had anxiety but did not, were not anxious about their cancer. Interestingly enough, there were just some people who the quality of the anxiety did not seem to be. We clinically felt like the people, or these people, would not benefit from our very tailored sort of intervention. Because I want to emphasize that this study was embedded within a psychotherapy protocol, which was very much focused on cancer-related kind of healing, I guess, like healing from cancer-related distress and anxiety. So participants had to have a cancer diagnosis, had to have anxiety about their cancer. It could be anxiety about, about death. It could be sort of a loss of a sense of kind of identity. A lot of people described feeling like they were constantly sort of running from their anxiety. They were very, and actually coming out with two papers, qualitative papers, which sort of described enrich or detail the kind of the narratives of the participants in our study. But essentially, what people were describing was real like existential fear that was prompted by a cancer diagnosis, and those are the people we really were looking for. People who felt like cancer overshadowed everything else, and their lives shrunk in the kind of context of cancer. So it manifested a little differently for everyone, but everyone who we ended up including. But for the most part, people, some people felt like it triggered this feeling like and this is a woman who actually was in remission and only stage 1 cancer, and she said, I feel like I'm dying inside, even though she physically at the time was healthy. And another person talked about just like just sort of the mind fuck, for lack of a better word, of just having of realizing you're going to die at some point, and probably in the distance between death and the present was becoming much smaller. So it just changed everything for them. So the people we were looking for were really the ones who felt cancer just this overpowering kind of force, and took away their ability to really to just be present in their lives. So that was kind of the psychological criteria, in addition to exclusion around not having a history of serious serious kind of mental illness, like a schizophrenia or bipolar disorder. I mean, it was pretty. We had very kind of strict criteria around the psychological potential comorbid diagnoses, and had to be pretty much just distress related to the cancer. And then we had a whole host of medical criteria, which was prohibitive for some people. But so it was sort of, that was one of the reasons why it was challenging to recruit, because participants had to have a certain life expectancy so that they could finish the study. Our study was 9 months long, so it was pretty long. They had to be kind of well enough to be able to complete the study. But at the same time, they had to have a diagnosis, and a potentially serious diagnosis, and be healthy too at the same time. To some degree, they had to not have liver failure, and brain metastases. They kind of had to, medically functioning enough to a certain standard. So does that answer your question enough about eligibility? Was there anything else you were curious to hear about?
No, I that's perfect. Yeah. Thank you.
You're welcome.
Yeah, I found it really interesting that the numbers kind of like pared down so heavily. But yeah, it makes sense with that story behind it.
Yeah.
The diagrams you guys included in the paper was really helpful too.
Good.
To understanding how everything flowed through and timelines. I think overall, if people are criticizing the placebo, that I think they need to look a little closer at psychedelic research and just realize that it's, it's going to be really hard. And there's no current drug or whatever that, I don't know, could simulate it closely enough and fool the therapist and the patient.
Well, it was interesting when I was at the MDMA training, somebody asked Michael and Annie that, and they said they had one session where they were kind of fooled. They had no idea. They thought somebody had active dose, and
actually we did too.
Yeah.
I'd be curious to hear more about that. Hear about their case, but we actually did. I should, qualify what I've, have been saying with that. I'm glad you bring that up because we did have one participant who had. So our trial was a crossover. Maybe I should explain that first, so that it's a little clearer.
Sure.
So every participant who received the medication, received a medication and placebo. So they were randomized to one group, one group being receiving the placebo first, the other group being the psilocybin first, and then they would take that, have that drug administration, and then there would be 7 weeks of time before they had the second dose. So I believe that I'm forgetting whether the Michael and Annie's study is I'm forgetting what the design is there, but it sounds like there's some similar phenomenon occurred because the one participant who was in the placebo first group received the placebo. 7 weeks went by. The second dose was the psilocybin. She subjectively reported that she felt like she was. I think what happened was she entered like a very deep meditation, and with the music that we provided, she entered this like very, very deep realm. I don't know how visual it was for her, but it was very deeply profound, I think, on a more embodied level. And that's what she described after that first session. And then in the second, she much more visual, but she she reported that both sessions were very impactful. And what we were able to determine later was that her scores on the instrument that we use, one of our primary outcomes being the mystical experience questionnaire, she scored. She basically scored not only like a similar, very high, like sort of above the threshold of what we have the researchers have defined as like a mystical experience, but just on the high ends of for both of them out of all of our participants. She had so even on her first placebo session, she appeared to have, or she endorsed at least on these self-report instruments, that she had a full-blown mystical experience, and even surpassed some of the other people who had received who received psilocybin on that first dose. So it's interesting.
Do you know if that person had some sort of spiritual or religious background, or had experience with like meditation or anything like that?
Yeah, so both. She actually, and I think that's an important variable or factor to consider. She had experimented quite a not so. I think we tried to take participants who were not were not totally children of the 60s. We kind of I would say that she was probably, we had maybe a couple of those of some of those people with this kind of more free-spirited personalities, but this woman in particular had experience, not an extensive amount, but had some profound experiences in the past with psychedelics while they were legal, I think, at the time. And then I don't know if she was maintaining a meditation practice, but she was a spiritual or spiritually inclined individual. So I think that definitely plays a part, as does there's some constructs that I think the researchers are now interested in measuring: absorption, so your ability to really become, or hypnotizability, to become absorbed in whatever it is you're experiencing. So I take it that she also was able to enter that state. And it may be related to, ability to kind of meditate, but it's all very interesting.
Because you guys use the blindfold, eye shades, and then music, right? I mean, for me, I can put some eye shades on, listen to music, and I'm off because I have this background in like breath work and stuff. It's just like I have a practice with meditation, and it's just, I don't know, I can enter into those states a little bit easily. And I just noticed from like breath work, it's like I know I lay on the mat, put the eye shades on, like even before the music starts, I'm already like having an experience. So no, that's great. I can imagine. But I think it does. So it's an interesting variable to consider. Yeah. So I'm kind of curious. Let's see, maybe we have like 15 more minutes or so. Maybe wrap up with some of the results for the people that haven't read the studies or seen the articles. And then I was kind of curious to hear about what you're doing now and maybe some speculations for the future.
Okay. Sure. So I guess I'll start. Let's see. So the paper, this is, I don't expect everyone to read it. It's quite dense. But let me see if I can synthesize the findings. So we, or at least at NYU, we administered one dose of psilocybin to 29 participants with cancer-related anxiety. And what we were able to, and I explained the crossover. So essentially, everyone received a placebo or an active psilocybin dose. And this was done in very supportive conditions. We, each participant had 2 therapists with him or her, and had extensive preparatory work prior, which involved, taking a life narrative, and they really sort of building therapeutic rapport between the therapists and the patients. Very much, I want to credit the sort of therapeutic protocol to this very much was inspired by the Stan-Grof model from the 70s at Spring Grove. So we really try to hew to that sort of supportive set and setting model where we created a comfortable environment and prepared participants to really have a deep experience about their fear and about their cancer, or about their fear as related to their cancer. So so it's important to note that that people were in some ways primed to enter in this altered state with an intention to overcome their. Everyone had a different intention, but the intention of this study was really kind of centered on healing from cancer-related distress, and specifically kind of the existential distress. So what we ended up finding was we administered a number of assessments, and there were some primary ones and then some secondary ones. The primary ones were related to anxiety and depression, and then some of the secondary ones were others like demoralization, death anxiety, and quality of life, spirituality. So we measured quite a bit, but I guess the most significant findings is that so essentially about 6.5 months later, after participants received either their psilocybin. This is so some people who received their psilocybin dose first, were measured sort of 9 months later, and then the people who received their placebo dose first, they had psilocybin 7 weeks. Basically, the time point in which we measured on average was about 6.5 months follow-up. And what we found was that about 6.5 months after receiving their second dosing session, their scores on these assessments of anxiety and depression had basically remained very, very low. So they came down immediately after their sessions, and then approximately 60 to 80% of the participants at the 6.5 month point, sustained these benefits, not only in anxiety and depression, but also in quality of life and improved attitudes towards death. And also, many of them rated the experience to be in the top 5 or single most spiritually significant and personally meaningful experiences of their lives. So that's quite significant as well, and also is a replication of the findings from Roland Griffith's kind of counterpart study. So that's kind of the gist of it. It's actually I'll add that another important finding is that what we were able to identify was the mediation model, which I'll explain. So what we were able to find was that mystical experience is, or at least statistically, was shown to drive the therapeutic effects. So that essentially means that the people who received psilocybin and then showed these reduced anxiety and depression symptoms, what we were able to statistically show is that the mystical experience people who scored high on the mystical experience questionnaire were also, though there was a correlation between a relationship, basically a positive relationship between those scores. So the higher, basically, the more mystical experience, the more of a mystical experience that you have, the more reductions you'll see. And the significant piece is that with this statistical model, it shows that that mystical experience is sort of explaining why. It's essentially the explanation for why a psilocybin experience reduces anxiety. And there's sort of a whole statistical theory for why that model does. But it's an important finding, because now we suspect and we'll need more data and more research to confirm this finding. But it's significant because we now sort of understand what is the ingredient, like what's the active ingredient that's producing these changes. And it may not just be mystical experience. There may be other, as a psychologist in training, I suspect that there are other maybe sub-dimensions of the mystical experience that might be, driving the experience more. And we'll need more research to understand the relationships, but it's pretty significant to basically claim and say that there's something about the mystical experience which entails there's I think 6 subdimensions of mystical experience. One of them being unity and transcendence of time and space, and feeling of interconnectedness. So something about the experience that engendered those the mystical experience, transcendence, et cetera, is responsible for the therapeutic effects.
So Kyle and I, being students of Stan Grof, that wasn't really a surprise to us. Yeah. I don't think that came out. But what's the response like in the field to that particular aspect, like stating something like mystical states are healing?
So,
like, a lot of people just doubt that it's a real thing anyway.
You mean so like more in the medical or like the traditional?
Right. Yeah. Yeah, absolutely. Like medical professionals looking at this thing.
Versus like me, who's like a trans person. I have a transpersonal background. And I'm like, yeah, mystical experiences can be really transformative and change your life. So right. It's like, how do you measure that? And then, bring this like correlation between the two, it seems tricky.
I know it is definitely tricky, but, interestingly, I was sort of not skeptical, but I think the field or the academic science field, who's working on the psychedelic research, I think we were initially surprised that we were initially cautious about using the term mystical experience, even in right. talks that Dr. Ross would gave. He would give talks quite often at the medical center and different just different academic institutions. But more and more now, I think. And what he shared with me was that it's becoming, oddly enough, more. I wouldn't say it's part of like the lexicon now, but it's being accepted as a valid construct that can be measured in scientific research, and I think that has taken some time, but. Definitely. Roland Griffiths, who has kind of led many of the efforts in this domain, to bring not just light to this dimension of experience, but to show that it can be quantitatively measured. He actually. There is quite a bit of history of the scales. There were some religious scholars Ralph Hood, one of them, who I think it was in the 70s, developed one of the mystical scales. So there is quite a, and based on Walter Stace also, who was part of the Good Friday experiment. I won't go off into that, but the construction of mystical experience scales have been around for quite a while, and with people like Roland Griffiths and I guess at our study at NYU, what we're doing is really bringing these already validated scales into into the work, and we're able to convince. I mean, I think physicians and medical researchers, for whatever reason, are able to, and maybe they don't entirely understand the mystical experience, but it's not a career killer, I guess, at this point to write about the mystical experience. And I think that was, to measure and use it as a construct right now. I think it's a relatively new development, but it's being received pretty well, as far as I understand. So it's interesting. We'll see where it goes from there.
Yeah, I'd love to see what kind of comments Richard Dawkins would have. Mm-hmm. So it's all hogwash. Yeah, blah, 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 blah. But probably not, because you guys actually have a pretty rigorous study. And you don't... I think you guys did a great job describing the mystical aspect. You called it mystical mediation through... There was like the neurochemistry and also like the mystical aspect.
Right. Yeah, there was a little pair. Yeah. Yeah, I know. There was... I think we did the sort of mechanisms. We talked about neurobiological, psychospiritual mechanisms was our second one, which I'm glad that it was interesting for you.
Yeah. And how did you actually get it publicized? Did you guys have a team that would send it everywhere, or did someone just pick it up and start writing about it?
You talk about like all the coverage that was
right, because there was a substantial amount.
So there was I believe I can talk a little bit about this, but there was a lot of build up and there were some conversations between PR teams at both institutions at NYU and Johns Hopkins that were anticipating this publication. Additionally, the commentaries that we collected were done. Let's see. And so when the article was accepted officially, I think it was in. I'm not remembering exactly when it was. Maybe in the summer when it was sort of the final review had been. We received the final review and it was ready to go to. It was accepted into the journal, and then a number of commentaries were received. So around that time, I think is when it became communicated, or when some of the PR teams at these schools communicated the news of the publication, which was, the publication was finalized, but it takes very long for it to reach the press. So in that interim period, I think a number of people were journalists were made aware of the impending paper. So I think that's what happened.
Cool. And what are you doing now? I just read in the part of the bio that you are co-leading another investigation with psilocybin.
Right. So I have been fortunate enough to continue my work with NYU through my through investigations, qualitative investigations on the a number of them actually. One of them we finished 2 papers actually. I working on a team of other doctoral students and then a few of us out of a larger group. We wrote a second paper that should be published in the next. We hope in the next couple months. We should have 2 papers that are coming out of our investigations of interviews, analysis of interviews that we collected from the participants, a sample of the participants who were in the study that was just published. And so that was a really rewarding experience, writing those papers and analyzing the very rich narrative data. And so that's coming to an end, but I am working on 2 other studies that will be also qualitative in nature, meaning that we are going to conduct interviews and analyze those interviews to sort of build a sort of bottom-up understanding of what's going on in these in studies. 2 studies that are going on at NYU. One of them, religious psilocybin administered to religious professionals, which is really interesting. And that's going on right now, as well as a psilocybin to treat alcohol addiction. Mm. So I'm involved in those 2 studies and sort of investigating different also domains of psychological constructs within the alcohol study. And then my other project is out here in California. I will be developing with another young qualitative researcher the qualitative study for a new study that's, I think, we don't know when it will begin, but it's going through the stages of review right now internally at UCSF for psilocybin to treat basically existential distress among HIV AIDS survivors. So in San Francisco. So that's another interesting one as well. And we'll be incorporating some, another passion of mine is my meditation and mindfulness. And what we're going to do in that study is incorporate some kind of experiential and almost kind of mindful body awareness to participants in the study before they receive their psilocybin sessions. And
cool. And is that one going to have some sort of group psychotherapy aspect to it? I was just reading.
Yes,
here.
Exactly.
That's really interesting.
I realized I just omitted that piece. So so that's a kind of groundbreaking, very unique design. So it will be, it will be a pilot study. So we will. It's not going to be a double-blind control. It's going to be a small study, but we will be basically measuring. Psilocybin will be administered individually, but it will be embedded within a group psychotherapy context. So participants will receive. They will receive psilocybin after a certain number of group therapy sessions. They'll have their psilocybin session, and then with one of the therapists. So there'll be 2 therapists who are leading the group therapy. There'll be like a 2-week period of individual, psilocybin sessions, and then after that 2-week period, the group will come back together to integrate and process together. But it is, a very interesting model that we'll be using for that study. and it's kind of, we hope to sort of engage the more social, interpersonal kind of mechanisms of healing into this, into the psilocybin work. So that's a really exciting development.
So when people approach you and ask, like, how can I get involved? Do you have a stock answer? Mm-hmm. Depending on where they're coming from, or what are your thoughts on getting involved in the field as I don't know, somebody doing a bachelor's somewhere?
So yes, I would recommend doing as much reading as possible. Kind of, it's wonderful that there is such a growth of good quality sites, media, news sites, and symposia too, and your podcast. I think it's quite a bit of quite a lot of ways to familiarize yourself with the the pulse of what's going on, I would say. But and if for people who are interested in entering the field, I think there are many ways to there's no one right way, but for people who are interested in doing like the medical clinical research that's taking place in the mostly right now within medical centers, I really recommend, and I think this is not an uncommon recommendation, but I think working really hard in whatever domain of whatever, whether it's be psychology or neuroscience. There are some kind of common domains of science, or particular, or just therapy, clinical work as well. But I think really, I think there's this there's this need to sort of obtain a mainstream education, which I think is hard, and it's been very hard for me to reconcile that with my more alternative interests. But I think the best thing is, for someone in college, for instance, is, to get a bachelor's. It doesn't really even matter which my bachelor's was in. I created my own major, and it was not even in the psychology field. It was a completely different domain. But it was, it was enough to get the bachelor's. And then I think for people who are willing to put in the time to either do some volunteer work or do a year or two of a research assistantship, or, somehow get into the team of an active study, which it's very competitive, but at the same time, there are definitely ways to do it and ways to pursue it, which is really what I did, and to get in, and get your in. And it may require, kind of a year of volunteer work, but the communities, and I don't think this is unique just to the psychedelic research community, but in general, I think it's a lot about networking. So the more that you can network in order to kind of secure a position within the team, or even going to conferences, I highly recommend going to conferences. And I think those are some of the best places to meet people and at those settings. There's a lot of, science, discussions, but there's also, there's a lot of opportunity to connect in this sort of community level, and to just have conversations and meet people who know other people. So, I wouldn't discourage anyone from working towards whatever dreams they have of being in this field. And I really do believe that that there will be many more opportunities for people to especially for therapists and especially for therapists who will for studies that will need clinical or other supports on their teams. So I think it's a good time to begin working your way into the field, because in the next 5 to 10 years, it'll hopefully the climate will be really
changed.
Welcoming.
Yeah, hopefully
changed. Exactly. Yeah, right.
Awesome. How about any other final thoughts or maybe visions of the future that you have?
Yeah, visions of the future. It is really interesting and really exciting to be at this stage of our evolution, if you will. And I guess on just like a collective psychological level, which is what I think about a lot. And I really do hope that we will be able to, I think that the path right now to the post-prohibition world is there's a lot of wisdom with the approach of the clinical medical route, which is really it will take many years just to get these medications and these medicines to people who are really suffering and really need it. But in terms of a kind of clinical, from a clinical perspective, but I also really hope that it will become available for all people who are suffering, and I think we all are suffering to a certain degree, and that the vision I have really is for the kind of expansion of our understanding of just the human, the human experience and the value of these medicines for all people, and in many ways to help heal the even the generational tensions that will probably beget pathology in the next generation. So I don't think it should be limited to to the people who are sick right now. But I do think that those are the people who need it. It's an interesting thing to think about. Who most needs it. But from a perspective of suffering, I think there are a lot of people who really are suffering, and psychedelics have a real powerful. Provide a real powerful tool to, in many cases, save people's lives in a very short amount of time. Especially for people who don't have the time to meditate, or especially for the cancer community, it's, I think, a real it really serves those people who just who don't have the privilege of time. So
it's a really great point. So, thank you. And thanks for highlighting like that, like the intergenerational stuff. I think that's really important. I think a lot of us hold onto and have a lot of intergenerational trauma. And I think, these could be good medicines to hopefully heal that collective conscious of trauma.
Right.
But yeah.
Exactly. Well, yeah, thank you for, for recognizing that too. I appreciate that.
If people have questions for you, can they reach out to you at all? Of course,
yes. So the best way to do that would be by email. Should I save that here, or will it be? Yeah.
Let's save that here. It'll probably get you less spam.
Okay, great. So my email is my first name, Gabby, Gabby. Dot. I'm going to spell out my last name because it's long. So Gabby.AGINLIEB as in boy, E S as in Sam @gmail.com. So Gabby.Agin-Liebes @gmail.com.
Awesome.
Perfect. Thank you. So yeah, thanks again for your time, and we'd love to have you on again in the future.
I would love that.
To chat about what you're up to and how things have developed.
Thank you so much, and thank you both of you for everything you do. And I know it's a labor of love, and I think it's really so great. It's very important work. So thank you.